Thank you, Professor Chao, for the introduction. And good morning, my colleagues and Professor Filippo Creel and Professor Lico Bruning. It's a great honor for me to present here. So first, we've looked at some translational studies. Now we move our eyes into the big trials. So there are a few big trials last year. So the topic today is landmark heart failure studies 2024 to 2025. What should change our practice? So I've actually looked at this article from European Heart Journal last year by Professor Bordek. So he has highlighted top 10 papers last year in heart failure. I'm going to show you, go through some of the trials and review some others as well. I have grouped these trials into four themes. One is regarding metabolic modulation in HFpEF. The second one will be device and monitoring advances. And thirdly, we go to the optimization and advanced therapy in HFrEF patients, and we go through some special populations as well. So now let's first look at the HFpEF therapy. So HFpEF was once deemed no disease-modifying treatments before. So ever since SGLT2 inhibitor, it started the new era of metabolic modulation for HFpEF. And now following that, actually, the first batch of three trials I'm going to show you are actually focused on this area. So now let's first start from finite heart failure. So I'm very honored to mention that our department actually take part in this trial and contributed to this trial. And now with the results, we actually say this finerenone in HFpEF and have mildly reduced EF patients. So finerenone, we all understand it's a new phase of non-steroid mineralocorticoid receptor antagonist. So from MRA, spironolactone had its own phase 3 trial, which was TopCat trial, that was done many years ago, had a mixed results actually, showing that there was positive benefit from subgroups, while excluding some of the regions results. So now with this question, will the new non-steroidal MRA bring benefit? This finite heart failure trial actually show us the evidence. So it included symptomatic heart failure patients with a LVEF more than 40%, with evidence of structural heart disease and elevated levels of natural uric peptides. And the primary endpoints was the composite of total worsening heart failure events, or CV deaths. And the results actually showed that the treatment group reduced primary outcome, but many driven by fewer worsening heart failure events. And the CV death was not significantly different. And with the finerenone group, actually had a higher risk of hyperkalemia and a lower risk of hypokalemia. With these findings, we actually should say that this first non-steroidal MRA showing an outcome benefit in both HFpEF and have mildly reduced EF, which is showing a promising new disease-modifying option, which is quite inspiring as well. And so secondly, let's go to STEP HFpEF DM. So semaglutide, is a GLP-1 receptor agonist, which is actually the second diabetic medication following SGLT2 inhibitor showing beneficial results for heart failure patients. So with semaglutide, they actually wanted to test its benefits in this group of patients. So the primary endpoints for this trial is change in body weight and KCCQ clinical summary score, which is quality of life outcome. So for this result actually showed inspiring result, showing that there is a significant reduction in body weight, which was showing in the lower part of the left side, the figure. And also an improvement in KCCQ CSS score. And also a improved 6-minute walking distance and a CRP. So this clinical message is quite clear, saying that GLP-1 receptor agonist may substantially improve symptoms and exercise tolerance in obese diabetic HFpEF patients, which actually proves that metabolic modulation emerges as a new pillar for this group of patients. And following that, tirzepatide, which was also mentioned by by previous presentation. So tirzepatide actually was a dual modulator. Actually, it is a both agonist GIP and GLP-1 receptor. So as with this function, is this medication benefits in HFpEF patients with obesity? So they are going from quality of life outcome into a hard outcome, which is the CV death or heart failure events. So this primary endpoint actually showing also beneficial. So the composite endpoint HR was 0.62, which decreased the risk of these events. And also for quality of life measures with KCCQ CSS score also improved. And also 6-minute walking distance and CRP improved. However, we need to notice that this medication's usage was actually limited by GI side effects, such as nausea and vomiting, and which led to 6.3% of discontinuation. So now this as a with a hard outcome benefit actually also bridges the obesity, inflammation, and cardiac dysfunction together to mention that GLP-1 and GIP dual functioning treatment may bring beneficial effect for HFpEF with obesity patients. So moving from that part, we actually go to device and monitoring advances. When mentioning devices, we know that for heart failure treatment, we have ICD, we have CRT. But now this new era actually has seen devices such as TEER for mitral valve, and monitoring devices for monitoring the water in the lung, and as well as pulmonary artery pressures. So ReShape 2 actually tested transcatheter mitral edge-to-edge repair in heart failure with functional MR patients. So we know that this treatment for this group of patients has been tested went back to 2018 with 2 trials providing conflict results. So this trial now was giving more evidence, beneficial evidence, and was in line with previous COPET trial. This trial was designed to include heart failure patients with a LVEF ranging from 20 to 50%, so many HFpEF patients, with moderate to severe functioning MR, and was tested, and the primary endpoints were set to be total heart failure hospitalizations and CV deaths composite endpoints, as well as KCCQ overall summary score. So now the result also showing beneficial, and heart failure, this composite endpoint and heart failure hospitalizations has been improved in the treatment group, and also the function, quality of life measures. And apart from that, now we have also mentioned that pulmonary artery pressure monitoring has been showing beneficial results from previous monitor heart failure trial, which was published back to two years ago, and also showing that this device cardio MEMS for pulmonary artery pressure monitoring has shown beneficial outcome in quality of life. So this newly published article actually tested, also did the subgroup analysis to test whether this is consistent in all the subgroups. So it tested for subgroups including ages, sex, whether the patients had atrial fibrillation, diabetes, how was the LVEF status, whether the patient received CRT and ICD or ICD. So actually all the subgroup analysis results had shown that there was no heterogeneity detected, which again supports a broad applicability of PA pressure-guided management in all these symptomatic post-hospitalization heart failure patients. And with these advances, now we go to the field of HFrEF therapy. So now we understand that HFrEF therapy had a very rapid progression in the past 30 to 40 years, and we have seen many categories of disease-modifying medication, what we now call included as a GDMT or GRMT, guideline recommended medical therapy. But now in real world, actually, we've seen that the prescription rate was remained problematic. So one of the major concern for this low prescription rate was that doctors may worry the side effects of GDMT treatment and the lack of confidence for these therapies. So a strong heart failure trial was published in 2022. So this trial aimed to test the rapid GDMT optimization after an acute heart failure event, so whether this is safe or beneficial. So this result actually very clearly showed that there is a beneficial effect from early structured rapid GDMT titration within 2 weeks after the event. So also it showed that the safety, the concern, which is quite safe during this protocol. So 2 more articles was published this year to further analysis the data from the STRONG trial. So one of these trials is GDMT intensity score and implementation regarded. And so this trial actually used a intensity score to test how was the compliance in this STRONG heart failure trial. So by saying that, because for a STRONG heart failure trial, they use these 2 methods. One is the rapid, or we call intensive treatment. Another group is the usual care group. So how was the medication usage in these trials? So they examined the adherence of both the doctors and the patients. So the result showing that the triple therapy at 90 days for these 2 groups actually was quite different. With intensive treatment, had a compliance rate was with 93.5%, and the usual care group actually was only 36%. And yet, this difference has transferred into a clinical outcome difference. With this test of GDMT intensity score, they actually show that this compliance score has a strong correlation with a reduced events. So which will give us more confidence with GDMT rapid titration. And also, these sub-analysis on the right side actually showing a sub-group analysis for STRONG heart failure trial, which has differentiated the heart failure patients with their etiology, meaning that ischemic group or non-ischemic group, whether they have difference. So the findings from that trial, from that article, actually showing there is consistent results across different etiologies. So again, give us more confidence. So apart from rapid titration, actually another trial, half-opt trial, has given us more confidence for prolonged GDMT treatment. So this trial was trying to determine the duration for guideline-directed therapy optimization in de novo HFrEF patients. So it included all the patients with HFrEF, and they will put them on a wearable cardioverter defibrillator, a WCD, and followed for 1 year. So they examined the LVEF for these patients and noticed that the LVEF actually improved through days, not only until day 90, but until day 180. It actually improved quite a lot from day 90 into day 180. So there's a period because we understand that the current guidelines recommended ICD consider we will relook the indication for ICD after an event, after the GDMT treatment for 90 days. But whether this prolonged observation is beneficial and whether it is safe, so this is the main aim of this trial. So now with the results, we can see that so prolong this waiting period, defer the ICD implementation into 6 months might be safe and beneficial. So may decrease the needs for ICD implantation. And with advanced therapy, LVAD, advanced heart failure, LVAD has been playing a more and more important role. And so Elevate Registry, actually, this article has provided some further look, some data in the real world. So it's showing that so for LVAD, HeartMate 3 LVAD patient, the 5-year overall survival was 93.3%, and the stroke-free survival was 58.1%. And also showed that there is sustained improvement in functional capacity and quality of life. And with that, with this growing population accepting LVAD, how is the treatment for long-term anticoagulation, whether aspirin needed on top of warfarin, ARISE HeartMate 3 trial has given its answer. So this trial included HeartMate 3 patients and has randomized to patients only accepting warfarin and aspirin. And the primary, so this is a non-inferior testing for placebo versus aspirin treatment. It showed that the survival-free of a major non-surgical hematocapability-related adverse events was actually higher in the placebo group, meaning that aspirin can be considered safely omitted in these patients on week A to reduce the bleeding burden. So the rest of my topic will focus on special populations. Now we first look at tadalafil in HFpEF patients with combined pulmonary hypertension. So tadalafil, we actually understand that it is a medication for pulmonary hypertension. So how is its role in HFpEF patients combined with PH? So this PASSION trial has tested, but sorry to mention that the trial has been stopped early due to a drug supply disruption. But during this period, during the limited period of the trial, it showed the all-cause mortality actually was higher in tadalafil group. So the clinical message showed that at this moment, we don't have a beneficial result for tadalafil usage in this group of patients. Sorry. And the last trial I'm going to share with you is this Europe PPCM trial, which is an observational study. It observed the usage of bromocriptine in peripartum cardiomyopathy patients, showed that yet this trial is observational, but the evidence is supportive for bromocriptine usage in moderate to severe PPCM patients. Okay, in summary, I have shared 4 groups of themes in heart failure therapy. These trials, so firstly, the metabolic, it is a new era for metabolic treatment and modulation for heart patients. The arising medications, including finerenone, a non-steroidal MRA, the GLP-1 receptor agonists, and dual incretins. So all of them actually showing very inspiring results. They might change our concept of diastolic dysfunction in the future. And regarding devices, hemodynamic strategies, they are actually helping us managing heart failure proactively. And strong heart failure and related work reminded us that speed and structure in GDMT delivery may save extra lives. And precision in special population continues to refine our care. So thank you all. This is the end of my presentation.